So our last speaker for this session is Annette Peters. She's the director of the Institute of Epidemiology of the Helmholtz in Munich, and also a full professor at the Ludwig-Maximilians University in Munich. She has an interdisciplinary background in epidemiology, biology, and mathematics as well. And a personal interest of her is the research in ultrafine particles and how they impact human health. She is here with us today to talk about the German National Cohort, NAKO, where she has a leading role since 2018. And we're happy to hear all the details from you today. Annette, please.
Yeah, so thank you very much for the kind introduction and also for inviting me to present the German National Cohort. And in a way, this is a health research infrastructure, but still my talk will be a little bit different because I want to place the work we are doing in genomic data into the whole concept of the German National Cohort. And I think when I started as an epidemiologist, I think it's important to remember these global challenges which we face in health, namely the climate crisis, the aging population, the corona pandemic, and the increases in social disparities. And cohort studies provide evidence where clinical trials are either unethical or unfeasible. And so this is why the German National Cohort, or NAKO, was incepted in 2009. It's the largest health, has recruited in 18 study centers a population-based prospective cohort. It is had aimed to recruit 200,000 men and women, who then were aged 19 to 70 years old. And it started in 2014 with data collection and is funded by the Federal Ministry, the states, and the Helmholtz Association. So the objectives are to identify pathways linking lifestyle and environmental risk factors to disease, to understand the geographic and socioeconomic disparities in health and disease in Germany, to develop risk prediction models, and to develop novel tools for early diagnosis of disease. And so the baseline examination was in 2014 to 19. We have just completed the first re-examination and have started the second re-examination. So it's a unique feature of the cohort that we actually invite everybody back for detailed examinations. In addition, we follow for incident events by questionnaires and secondary data, something which unfortunately is in Germany so much harder than in the UK or in Scandinavia. And then we have quality assessment and data preparation. So what we do in a nutshell is we have a wide sweep of physical examination. We have interviews, we have questionnaires, we have magnetic resonance imaging. Again, this also repeated. We collect biosamples. We had a COVID-19 component. We collect information on biomarkers and follow everybody. This is the age distribution. So we have 20% of the individuals who are between the age range of 20 to 40. And then we have 80% in the age range of from 40 to 69. It turns out that recruiting people to a cohort is really difficult in these times. So you'll see here the response proportion by age and sex. And you see also that it was really hard to recruit younger individuals into the study. And it was also more difficult to recruit men than women. We had the ambition to recruit the 200,000 at baseline, and we were offering the in-depth examination to 40,000 individuals. For the first re-examination, we planned to see 135,000 individuals, and now we are aiming at 65,000. We have a quite ambitious biosample collection, and we have the magnetic resonance imaging component, where there were 30,000 planned initially, and now had planned 18,000 and nearly 12,000. And we are open to level 3 examination. So if people come with additional question, they can join the study with their protocol. And so what have we achieved? We actually completed everything we wanted so far, and we have started to nearly already see the next 8,000 individuals. And also the biosample collection was as expected. And down here you see the numbers again for MRI. We really completed what we wanted to do. And so first results, one thing we did was when the COVID pandemic hit us, we actually had to stop the study for 3 months. And during this period, we had a questionnaire indicating that indeed there was an increased stress level, depression, and anxiety during the COVID pandemic, both in men and women. And that led to the loosening up the towardness or the ambition in the second lockdown period. Also, what we were looking at is that actually economic stability, which is driving or which is impacting the people. And indeed, we found that if we adjust for the job security or socioeconomic status, then the effect of the stress and anxiety and depression was taken up, saying that indeed our social system in Germany is really helpful in preserving health. And finally is how can we assess aging, and can we assess the indicators for functional decline. And a fun story is actually grip strength, where one sees that it kind of plateaus until the age of 40. And it's actually the only parameter where you do not start to declining as of 25 or 30. And indeed, this is linked to disease and thereby provides evidence on biological aging. And I think this is important because magnetic resonance imaging is also one of these great tools where you can learn of early markers of disease as well as aging. So we have 5 centers across the country where we do a whole body MRI protocol. It's standardized with similar scanners. We have an incidental finding strategy and a central MRI data management. And what is interesting is, and I think this is also speaking to the needs, what we will need into the future, is that we can use NAKO for the population aspect and healthy subjects, but we can also integrate this with clinical data. So this is data derived from Alzheimer's. And then if you think that you use this for age prediction, you see that, yes, you can predict chronological age of organs, here the brain. And you also see that based on our design that we had fewer people between the age of 20 and 40, you have less accuracy, as you see here, and you can do this regionally. So I think this is important because in the future, we really would like to integrate our genomic as well as our imaging data across the population, but also across patients. And so the other important point is that we need to have data integrated across different cohorts. So this is a neat example with looking at the fat distribution of pancreas, here integrating data from the UK Biobank and the NAKO. So the UK Biobank you see in brown, and the NAKO data is just below that in blue. And you see that because we had the lower age range, this is, we can go to lower younger people, but you also see that the distribution, as when we were learning these images separately, was higher in NAKO. And now if you learn them together, you can actually integrate this data. And again, I think this is something we probably also want to see on the genomic side when we come to use the data. And so I would like to move on with the work on biorepository genetic and molecular phenotyping, which has just started. So these are the novel developments. But let me first start with that we have a central biorepository at Helmholtz Munich, which is innovative. And it's one of the unique selling points of NAKO that actually we have a complete cooling chain. So our biosamples are actually of higher quality than of other large-scale cohorts. And so we have stored urine, blood, saliva, nasal swabs, and stool so that we are able to do genomics, transcriptomics, but also metagenomics to characterize our subjects. And now moving forward, we are genotyping everybody currently. We have a proof of concept study with multi-omics layers in 5,000 people, which are funded in the current funding period. And we are now moving forward with 25,000 whole genome sequences. With a little bit more detail, we have now the DNA samples available, and we are designing a NAKO prevention chip, which is kind of aligned with the UK Genome Initiative prevention chip, which is also to be implemented in 5 million individuals. And this is just being started early next year so that the data will be available in 26. The multi-omic proof of concept study will do for the first 5,000 individuals with MRI examination, and we will be looking at methylation, metabolomics in blood, as well as metabolomics and proteomics in urine, serolomics, and we have a microbiome project, which also goes along. And again, this is starting, and we have started to select the biosamples and will be on the machine soon. And finally, the sequencing of more than 25,000 individuals is looking at whole genome sequencing. There is, one piece is the start of the proof of concept study funded by the Helmholtz Association, which will provide 15,000 participants, and we are starting early next year. And then we are also part of Genomes of Europe, where there will be a newly sequenced another 10,000 individuals. And I was just kind of eager listening to the requirements. One thing we are going to do is that we actually recontacting everybody in NAKO. So we estimate that we will get into contact with 150,000 individuals and specifically collect consent to be able to really enter the European data space and have it federated. And so that we would also be in the position that if there's more sequencing added to NAKO, that if we are sequencing additional people who then would be also have consented to be part of the federated European data spaces, that we could add them in the future. And this is an old slide from Oliver, actually. So where the vision is really to integrate this data within GHGA and use all the now built up infrastructure, but thereby also ensuring that we are visible in the European data space and beyond through these projects. And I think this is indeed very important. And I just would now like to put the last vignette forward, namely the other complexity through environmental data, where we are starting to link air pollution, urbanicity, greenness, air temperatures, relative humidity, noise, soil moisture, and social deprivation. So other kind of large-scale databases. And yes, I'm an environmental epidemiologist, but I've always also worked with molecular markers. And one of my big quests is actually to find genome environment interactions. And this has proven to be really difficult based on regular genotyping, but I'm really hopeful that if we now move into sequencing, we actually will identify genomic structures which may be may be impacted by environmental signatures. So something what I would be eager to do is also reintegrate sequencing data with different environmental structures. So this is another data infrastructure which is integrated. And why is this so important to my mind is because this is something where public health can actually operate. And so we had until yesterday particulate standards which were at 25 microgram per cubic meter, even though the WHO had indicated 3 years ago that it should be at 5 micrograms per cubic meter. But yesterday, finally, we passed the law that this will be 10 micrograms per cubic meter in the future. And we're also foreseeing NO2 as being changed. And so this is really something where the cohort studies can make major contributions. And figuring in the molecular data gives you sensitive reads out that environment is really relevant. And just to also something to put the bigger picture, we are experiencing climate change in Europe. These are maps of Germany. Germany is actually heating up more than many other countries. And you see that it's not every year the same. In some years we have hotter areas, and it's not always the same areas which are warmer. And so if we now look to the German National Cohort, we actually compare the people which we initially recruited in 2014 with them of 2019. We see that the temperature actually is already increasing in our participants, and the variation is increasing, especially in large metropolitan area like Berlin, for example. And so that we need to look at the more frequent weather extremes and also understand how complex environments interact in times of climate change. So with that, I would like to summarize. And to me, cohort studies make fundamental discoveries and guide prevention. NAKO is well established, and genetic and multi-omics characterizations are underway. And I think it's important to make this data really available to a large research community to be able to integrate it with approaches from clinical sides, as well as integrate it across cohorts. And I think we need powerful and sustainable data infrastructure to optimally use the NAKO data. And here I would make another pledge. We are really in times of climate change. So I think if we are now building in data infrastructure for the next 30 years, so decades to come, I think they need to be sustainable to be there all the time, but they need also be sustainable in the sense that they need to be carbon neutral. So I think we should think about how we do this in the future. And to my mind, cohort studies such as the NAKO address challenges of tomorrow. And there is a baseline paper where you can read up all about the data. And this is the team which puts up the infrastructure component we are responsible for in Munich. And with that, I thank you for your attention, and I'm very happy to answer questions and go into more detail if needed.